Baltimore suburbs and the Washington suburb counties around the nation's capital. But Maryland has a large rural population. In the western part of our state, eastern part of our state, southern part of our state, northern part of our state. It's central Maryland is more urban, but the rest is pretty rural. So this is an issue that is important to Maryland. It's important to every state in our nation. Rural communities have challenges today. 1 out of every 5 older Americans live in rural communities. It's an older population. It's a population that has less access to healthcare providers. When you take a look at the recent statistics from the Health Resources and Services Administration, they estimate that nearly 13 million adult citizens in rural communities have behavioral health issues that need healthcare attention. And yes, they're about half as likely to have a healthcare provider to provide those services. These are gaps in our healthcare system that we need to take a look at and find ways to improve. We know the workforce challenges. We have a workforce challenge generally in healthcare today. We recognize that, and COVID made it more challenging because they're frontline workers. So in rural communities, it's even more difficult to be able to attract the workforce that you need. These are areas that we need to take a look at as a committee as to what we can do to help. One of the areas that I've concentrated on since my days in the Senate has been oral health care. Oral health care is a general indication of general health care. We know that we've had challenges in access to oral health care in all of our communities, but in rural America, it's even more challenging to get the health care professionals that are needed for regular oral health care needs. So these are some of the areas that we want to take a look at. When the Affordable Care Act was passed, I was proud to be the sponsor of the amendment that established the National Institute for Minority Health and Health Disparities. Well, many people think that concentrates solely on racial minorities or ethnic minorities, but it also deals with underserved communities, and rural America is certainly an underserved community. So it's one of the areas of attention that we need to deal with in the United States Senate. There have been a lot of innovative approaches. I've seen in my own state of Maryland really excellent opportunities to try to close the gap. Several years ago, I was in Pocomoke City, Maryland, pretty rural part of our state, located all the way down the lower eastern shore. They were using telehealth well before it's become a more popular option in order to provide access to care that otherwise would not be there. I've seen creative alliances. In Maryland, we had the Garrett Regional Medical Center located in Oakland, Maryland. That's as far west as you can go in our state. They have an alliance with the West Virginia University Health System, which has allowed them to get the sophisticated care at their hospital that otherwise would not be able to be given. And the use of our qualified health centers has also helped us bridge some of the gaps. So today at this hearing, we have a distinguished panel of witnesses that will help us sort through what we can do as far as policies in the United States Senate to help provide greater access to health care in the rural communities. Before turning to our witnesses, let me turn to our distinguished ranking member, Senator Daines.
Chairman Cardin, thank you, and thanks for your tireless efforts in health care over the years, and in oral health care, as well as just for the champion for the rural parts of our states. It's also a pleasure to be joined today by Ms. Erin Awney from Glasgow, Montana. There's rural, and then you get out to eastern Montana. That is rural. We'll have a more formal introduction soon, but Erin, thanks for making the trip here to represent our state in rural health clinics. We're very glad you've made the long journey. There's no easy way to get from Glasgow, Montana to Washington, D.C. Rural health is a key component of America's health care. It's a greatly important issue in my home state of Montana, as more than 720,000 Montanans live in designated rural areas. That's about 3/4 of the population of the entire state. Most every state in the nation, as the chairman indicated, is true in Maryland, have some semblance of a rural population. And in frontier states like Montana, we are all too familiar with the challenges that come with living where we do, including the challenge of accessing health care. When we consider health care in a rural setting, one of the defining characteristics of access to care is distance as well as logistics, which more specifically means transportation. The majority of people in rural America live great distances from their nearest healthcare provider. A trip to a hospital or a doctor's office often requires traveling several hours, sometimes a full day one way. Not only is this highly inconvenient and straining, but also very dangerous in emergencies. Extreme weather, that's where it can take a full day sometimes in states like Montana, and unpredictable terrain only add to the challenges that our folks in rural areas face. Other threats to access we see disproportionately affecting rural communities are the increasing number of hospital closures and service line erosions. As our witness, Dr. Holmes, can attest, we've seen nearly 150 rural hospital closures in the past 13 years. While closures briefly stalled in 2021, this can largely be attributed to provider relief funds and other assistance to keep providers afloat during COVID-19. Now, as we move beyond that pandemic, the number, sadly, is on the rise again. I also hear too often about the erosion of service lines in rural America. In these areas, one of the first services to be eliminated is obstetric and maternity care. GAO, in fact, issued a report just last year which found that access to these services has been in steady decline, and more than half of rural counties do not have these services available at all. In fact, we just heard the story about a fellow Montanan, a woman who traveled from her home several hours away from Billings weeks leading up to her due date. She moved in a hotel so that when she went into labor, she'd be able to get to the hospital for her delivery. Preparing for labor, delivery, and newborns is difficult enough. No expectant mom should feel the need to go to such drastic lengths to receive routine prenatal and delivery care. This is just one example of how service line erosion impacts rural residents, but it's illustrative of the challenges we need to help address, and this hearing will help us in that regard today. We must find sustainable ways to keep health care accessible in our rural communities. To that end, I'm looking forward to the discussion today from our colleagues and witnesses, hearing their perspectives. The last time, by the way, the Finance Committee had a robust conversation about rural health was 5 years ago in 2018. I'm glad we're revisiting the conversation today. Again, I want to thank the chairman for his leadership here. We're doing it post-pandemic to examine the difficulties and progress over the past 5 years. We're proud of Senator Grassley's leadership. In January of this year, the first new Medicare rural provider designation went into effect since the critical access hospital designation was created all the way back in 1997. We're proud of the Montana leadership which led to this designation. I think about my Boy State speaker in Montana was a guy named Max Baucus. He spearheaded this, and now it's great to see Senator Grassley and others working to implement new and creative ways to serve the changing needs of our rural hospitals today. So thanks to the witnesses who, if you're from rural parts of our country, it wasn't easy to get here. We appreciate your expertise in the subject. Mr. Chairman, I'll turn it back to you.
Thank you, Senator Daines. Senator Daines, I want to yield to you for the introduction of your Montanan who's here.
Thank you. You even said Montana correctly. You know, there aren't a lot of us out there. You stuck the landing there. Thank you. Mr. Chairman, I'm very glad to introduce Ms. Erin Awney this afternoon. Ms. Awney serves as the Vice President of Strategic Programs at Francis Mahan Deaconess Hospital in her hometown of Glasgow, Montana. Previously, she served as the Director of Glasgow Clinic Specialty Care Division at FMDH, overseeing orthopedics, general surgery, OB-GYN, and the operations and marketing of Highline Med Spa, which she helped launch, bringing a new service line to that community. She's been with FMDH for 8 years. She serves on the hospital's senior leadership team and also serves on the board of directors for the National Association of Rural Health Clinics. Ms. Awney is very active in volunteering and participating in community events. She serves in the Glasgow Chamber of Commerce Board of Directors for the past 10 years. I'm just getting tired reading your background, Erin. Ms. Awney's also been married for almost 14 years to her husband, Jake, a mom of 2 boys, aged 10 and 12, who keeps her busy with sports. Her oldest son had a stellar wrestling season this year, securing his spot on Team Montana and helping lead the team to the National Dual Tournament in Des Moines, Iowa. When you're in Iowa and you're wrestling, it's big time. I know that. She also serves on the board of directors for the Glasgow Wrestling Club and that her children are active participants in. Ms. Awney, we're truly grateful you took time out of your busy schedule to be with us here today. I look forward to hearing your unique Montana perspective on the challenges as well as opportunities we face in rural health care. Mr. Chairman, thank you.
Well, welcome. It's wonderful to have you here, Ms. Ani. The next person I'm going to introduce is a Marylander. Ms. Sarah Rich is President and CEO of the Choptank Community Health System, has a master's in public administration from Western Michigan University, and over 25 years' experience in local, state, national, and healthcare settings. She joined Choptank in 2007 as the Vice President of Community Programs. Ms. Rich was named the Senior Vice President and Chief Operating Officer at Choptank in June of 2015, and in January 2017, she was appointed Choptank Community Health Systems Board of Directors by the Board of Directors as their CEO. Our third witness will be David Herman. Dr. Herman serves as Chief Executive Officer for Essentia Health, an integrated health system headquartered in Duluth, Minnesota. Dr. Herman oversees 77 clinics, 14 hospitals, and 15,000 employees who care for patients in rural Minnesota, Wisconsin, and North Dakota. Dr. Herman is a native of International Falls, Minnesota. He received his medical degree from Mayo Medical School in Rochester, Minnesota, and completed his residency in ophthalmology at Mayo School of Graduate Medical Education. And our fourth witness is Mark Holmes. Dr. Holmes is the director of the Cecil G. Sheps Center for Health Services Research and the North Carolina Rural Health Research Center at the University of North Carolina at Chapel Hill, where he specializes in rural health, including hospital finances and federal payment policies. If you can explain all that to us, we will use your help. He's also a professor of health policy and management at the Gillings School of Global Public Health. He grew up in rural Michigan, another person from Michigan, I'm telling you. Senator Stabenow has a great deal of influence on our selection of witnesses. We'll start with Ms. Ani.
Good afternoon, Chairman.
By the way, your full statements will be made part of the record. You may proceed as you wish.
Okay. Good afternoon, Chairman Cardin, Ranking Member Daines, and members of the subcommittee. Thank you for the opportunity to discuss the obstacles and opportunities in rural health. My name is Erin Ani, and I'm the Vice President of Strategic Programs at Francis Mahon Deaconess Hospital in Glasgow, Montana. And I also serve on the Board of Directors for the National Association of Rural Health Clinics, which represents over 5,300 CMS certified rural health clinics in 45 states across the country. During my testimony, I hope to take you on a journey of what it is like to access and help to provide health care while living in the heart of rural America. The Rural Health Clinics program was created in 1977 and remains the oldest federal program aimed at improving access to outpatient care in rural, medically underserved areas. The RHC program as a whole serves approximately 37.7 million patients per year, more than 11% of the entire population, and approximately 62% of the 60.8 million Americans that live in rural areas. The RHC program is a separate facility type from the federally qualified health center program, also represented on today's panel. Both serve a critical role in our country's health care safety net. I feel fortunate to represent one of those rural health clinics located in Glasgow, Montana. And now, if you're picturing mountains, we're not that side of the state. Glasgow lies in the northeast corner of Montana and is an agricultural community with big skies and wheat fields as far as the eye can see. Glasgow has been deemed the middle of nowhere by the Washington Post, as it is the most geographically isolated area, taking 4.5 hours in any direction to get to a city. As a provider-based RHC attached to a critical access hospital, we have no choice but to be very strategic on how we can best serve our community and the surrounding areas. Glasgow has a population of about 3,500 residents, 7,600 people live in the county, and about 15,000 in the two neighboring counties. Fort Peck Indian Reservation is also located 15 miles to the east of us. With the closest major hospital over 300 miles away, we work very hard to provide our service area with as many service lines as possible to relieve some burdens for our patients. Our RHC provides a wide range of services, including primary care, behavioral health, general surgery, orthopedics, and OBGYN. We are especially proud that we recently achieved 24/7 coverage in general surgery, OBGYN, and orthopedics. My testimony today will focus on specific challenges and solutions in the workforce, as well as access to care barriers like transportation. I encourage you to read my full testimony submitted to the record for further detail. As is the case for other rural areas, recruitment challenges are significant in the middle of nowhere. After years of provider turnover and unfilled openings, we strategically found a staffing model which would allow us to provide specialty services locally. And in 2020, we contracted with a company that provides 7 orthopedic coverage. The providers are a team of 3 full-time employees covering the month on a rotating basis. This model works so well that we expanded to general surgery and OBGYN and are now considering it for radiology. Being able to offer these services locally provides better patient outcomes, continuity of care, a better work-life balance, and helps prevent provider burnout. Further, we've sought to inspire our youth to pursue careers in health care based on the quality of care they receive from our organization. This year, we will be hosting the first med camp for kids in grades 6 through 8, introducing them to multiple areas of the hospital and clinic. For other service lines, including behavioral health and maternal fetal medicine, we're exploring the use of telehealth services and outreach. While partnerships to offer telecrisis services through our emergency room are working well to address some of these needs, offering telehealth services presents challenges as well. A great deal of our patient population does not have access to a computer, the internet, or a phone. These services may seem like a great solution to help bring care to the patient, but when they cannot access the care, it becomes more of a burden and frustration to those we are seeking to help. Many of our patients travel 50 to 100 miles one way to attend an appointment at our facility, which leads me to one of the biggest barriers our community is facing, transportation. I can share many stories with you, but one that stands out is from this winter when a patient presented to the ER by ambulance, a non-emergent ride, which was denied by Medicaid. After the patient was discharged, they were planning to walk 30 miles home to Fraser in a temperature of negative 35 below with windshield. We need more systemic solutions to address the impacts of transportation barriers. Canceled appointments lead to lapses in care, and this is only heightened when they need a higher level of care at a facility hours away. My clinic is just one of the 5,300 RHCs across the country providing critical services in innovative ways to serve the needs of our patients. Issues such as outdated conditions of participation for the RHC program, reimbursement disparities in health coverage, and a drastic increase in Medicare Advantage enrollment without a protection for RHC reimbursement challenge an already overwhelmed workforce and threaten the delivery of quality and outpatient care in rural Americas. I want to thank you for inviting me to share these unique perspectives as part of today's hearing. I am proud to be a voice and advocate for this population. I look forward to seeing the work we can do together for the over 60 million individuals across rural America. Thank you.
Thank you for your testimony. Ms. Rich?
Good afternoon, Chairman Cardin, Ranking Member Daines, and members of the committee. Thank you so much for the opportunity to testify today. As President and CEO at Choptank Community Health, I'm honored to represent the more than 1,400 health centers that are across this country. In 2021, health centers provided services to more than 30 million people. Health centers deliver primary health care to the nation's underserved individuals and families, including 1 in 3 people living in poverty and 1 in 5 people living in rural areas. Choptank Community's health system's mission is to provide access. We want to provide access to exceptional, comprehensive, and integrated health care for all. Since 1980, we've been providing access to quality health care through the delivery of medical, dental, and behavioral health services, now in 5 counties representing 7 locations on Maryland's Eastern Shore. In 2022, we saw more than 30,000 patients representing 99,000 visits. In my written testimony, I shared several obstacles that rural communities face in accessing health care and how community health centers are working to overcome those obstacles. This afternoon, I'm going to focus on 2 of these obstacles, workforce and access points for care, and certainly how Choptank is working to overcome those in an innovative way. So Choptank, along with other rural health centers and really healthcare systems all over the country, are experiencing unprecedented shortages in attracting and maintaining a qualified workforce. At this time, we are recruiting 43 open positions at our health center. 15 of those are providers, and those represent medical, dental, and behavioral health. And we have 28 positions open for clinical and support staff throughout Choptank. So what do we do? Well, at Choptank, we know and work on having a robust recruiting effort. We're always working on how we can improve it, tweak it, and make it better. At the same time, we've recognized that we have to have a pipeline of providers and clinical staff. We need to be looking at grow your own programs. And so we are working on that. Some of our efforts include a collaboration with the University of Maryland School of Medicine and the University of Maryland Shore Regional Health to design a rural family medicine training experience for graduated new physicians. We know that physicians who train in a health center are nearly twice as likely to begin their careers in a similar setting, providing significant benefits in the rural communities that they serve. We also have expanded a longstanding partnership with NYU Langone for advanced education in general dentistry This program is really critical in providing access to oral health care in our health centers, and it does serve as a recruiting resource. We've hired many of the dental residents that came to Choptank and hired them when they did complete their training. We also have plans in the works to add a pediatric dental residency as well in partnership with NYU Langone. We've also partnered with a local community college to address the shortage of clinical support staff. So we've developed a scholarship program to support the certification for medical assistants and dental assistants. So meeting people where they are to provide access to care is vital to meeting the mission of health centers, and Choptank is no different. We reach the communities that we serve in a variety of ways, and one of those is through school-based health centers. We started school-based health centers at Choptank back in 1999, and at this point in time, we have 30 health centers that are providing not only medical, but dental, behavioral health, and nutrition services. Often these centers are the only method of health care that these students are receiving. We've also had 3 mobile units that we've added to our access delivery model that have helped us reach the communities we served. Outfitted for medical and dental services, the units travel across the midshore to community events, and they are providing really important health screenings. And Choptank's presence at these events helps to build credibility and increase trust as well. So new access point funding for new health centers, including funding for mobile health units and school-based health centers, is needed. We certainly recognize that there are budgetary restrictions, but we do know that investing in health centers saves the health system an estimated $24 billion annually in reduced medical expenditures. Not only that, but expanding our reach as health centers will positively impact America's health outcomes. We know how to provide the access to care. We need funds to continue to do this work, especially with many of the obstacles that we're hearing about this afternoon. So thank you for your time today. I really have only scratched the surface of obstacles and opportunities, but I do want to leave you with this. Community health centers like Choptank are passionately committed people. They are very committed to providing quality health care, and we are part of the solution in providing access to medical, dental, and behavioral health services, especially in rural areas. Health centers are innovative in putting together new programs and services and partnerships, which is really key. And all of this will impact America's health outcomes. So again, thank you, Chairman Cardin, Ranking Member Daines, and members of the committee. I look forward to your questions.
Thank you very much for your testimony. Dr. Herman?
Chairman Cardin, Ranking Member Daines, and members of the Senate Finance Committee, Subcommittee on Health Care, thank you for the opportunity to testify today at today's hearing on improving health care access in rural communities. We deeply appreciate your invitation to speak with you today on behalf of Essentia and about our commitment to value-based care, which has demonstrated significant benefit for our patients. Essentia Health is an integrated healthcare system serving predominantly rural communities in North Dakota, Minnesota, and Wisconsin. We are all too familiar, as our colleagues are, with the unique combination of healthcare challenges facing rural residents across the country. It has been said that value-based care can't be implemented in rural America, that it just doesn't work. In our experience, we have found it's the only thing that really does work. This approach to care focuses on improving overall patient health with an emphasis on wellness and prevention. It's about connecting patients with the appropriate care at the right time and providing coordinated care throughout the patient's journey. Through the tools and infrastructure built to support this work, we better manage chronic conditions, reduce avoidable hospital admissions and emergency department visits, and improve the quality of our care. We know that our patients' goal is not to consume health care, it's to be healthy and lead better lives. Value-based care allows us to provide care in thoughtfully planned ways that results in excellent health outcomes and lower cost. Simply put, value-based care is the best model for rural patients and for all patients. It is neither practical or proper to differentiate the way we care for patients based upon their enrollment in a value-based program. Stratifying patients by their clinical and social needs rather than by payer is the most effective and most equitable. Our approach creates a model of care delivery that is as standard as possible and unique as necessary to meet the needs of our patients and their communities. Recognizing that this is the best model for all patients, Essentia Health began a shift to value in 2005 when we entered our first value-based contract. This led us to be an early adopter of dual-sided risk models and Medicare shared savings programs and Minnesota's Medicaid initiative called Integrated Health Partnerships. Today, We have 23 value-based care programs with both government and commercial payers, with more than 200,000 attributed members. In fact, nearly 40% of our health system revenue flows through value-based programs, and we continue to work to grow that number. So how did we do this as a health system that serves so many rural communities? Our success starts with a strong clinical and information technology infrastructure made possible by the scale of our integrated health system. Our robust electronic medical record allows us to better understand our patient populations and to screen for the social determinants of health. In 2022, more than 144,000 Essentia Health patients completed our health-related social needs screening, and more than 20,000 of those patients identified at least one social need related to food insecurity, transportation, or financial difficulties. Informed by that data on our patients, our care teams work together to address needs and care gaps. Yet we realize we can't do this all on our own. We have implemented an online platform called Resourceful that links our patients with a host of community resources. Providers can make referrals right from the electronic health record and then learn through a feedback mechanism if that referral has been completed. Through this work, we are helping real patients and saving real dollars. From 2018 through 2021, Essentia Health saved the federal government more than $42 million thanks to our Medicare Shared Savings Program participation. We saved $28 million for the Minnesota Medicaid program. Collectively, across all programs, governmental and commercial, Essentia Health has removed over $102 million from the cost of care through all value-based programs. At the same time, the quality of our care continues to improve. In 2021, our providers earned 98% of the Shared Savings Program quality targets. In the latest quality report from Minnesota Community Measurement, we were one of 2 organizations attaining the high-performing status in 13 measures, which is the highest performance in the state, with a primarily rural population. The move to value-based care requires a commitment to a new approach and continuous quality improvement. A shared IT infrastructure to support rural providers in this journey is the key, along with partnerships with community resources. Lawmakers can support this work by aligning financial incentives with value-based care and protecting critical safety net programs that help rural hospitals. Thank you once again for the opportunity to share our success with value-based programs in the rural communities we're privileged to serve. I sincerely hope that this can become a premier care model for sustainable health care in rural America.
Thank you, Dr. Herman. We'll now go to Dr. Holmes.
Good afternoon, Chairman Cardin, Ranking Member Daines, and members of the committee. Thank you for the invitation to appear here today. My bio was read earlier, but I think more importantly, I mentioned having grown up in Caro, in Michigan's rural thumb, with family members still there, I have a deep personal connection to rural health. I'm unable to cover all of the salient issues in rural health today, so I will focus my comments on 3 main points. First, the rural healthcare infrastructure continues to erode, threatening the health and well-being of 60 million rural Americans. Second, Congress can address some specific policy issues in rural health workforce. Third, rural communities have shown remarkable innovation, and recent policy initiatives have been successful. Rural-urban health disparities are well known. In the last 2 decades, the rural-urban mortality gap has more than tripled. Rural COVID-19 death rates surpassed urban rates as early as September 2020. But we also need to think about less visible disparities. My family members who had to drive an hour each way or stay overnight to get their radiation treatment, so facing expense and the fatigue of long car travel while in the midst of fighting cancer. Pregnant people who live in a rural community where the hospital OB service has closed will worry about whether they will be able to reach a provider in time for the birth or go to a hotel and make sure that they're there in time. The frustration and exhaustion of rural residents with opioid problems or issues who must wait in an emergency room for hours or days before a transfer to a mental health facility. Fatigue, worry, and frustration don't show up in official statistics. Since 2005, nearly 200 rural communities have lost their hospital. Although roughly half of these hospitals have continued to provide some kind of health care to their community, the remainder do not. Because hospitals are typically one of the largest employers in a rural community, closures can have large economic effects. Hospitals are typically one of the most important healthcare providers in a rural community, and many have had weak and declining finances for years. In 2018, roughly half of rural hospitals were unprofitable, and financial distress is one of the leading causes of rural hospital closure. As hospitals close, residents face a decrease in healthcare access. Congress, the Medicare Payment Advisory Commission, and others have long proposed new models of care that focus on a hospital's emergency department services. Senator Grassley's dedication to this issue manifested in the Rural Emergency Hospital provision in the Consolidated Appropriations Act of 2021. I applaud Congress for acting innovatively to address rural health needs. Continued monitoring of this provider type will be necessary to ensure it is meeting the needs Congress intended. Rural places have long faced persistent workforce shortages. Many proposed policy solutions to address these workforce challenges focus on one profession, for example, nurses, or one stage of the career, such as graduate medical education. To shore up and grow the rural health workforce, it is critical that we look to solutions that aren't siloed in this fashion and support healthcare workers across their entire career trajectory. Health professionals that train in rural areas are 5 times as likely to remain in practice in rural areas. Evidence-based investments that increase the number of health professionals training in rural areas, increase the number of preceptors and faculty, provide support to early career healthcare workers, address workplace violence, and focus on retaining mid to late career healthcare professionals have been shown to work and could be expanded. By growing the number of rural training opportunities and then ensuring that resources are available to retain that workforce across their careers, we can ensure that the workforce needed to meet the needs of rural areas is there for decades to come. We commonly hear about rural America being sicker, poorer, and older. These are accurate descriptions of a population that provides much of America's food, fun, and fuel. As much as it describes the health challenges in rural communities, I worry that it suggests government is powerless to improve rural health. In fact, when Congress and other policymakers have developed policy to address rural needs, it has improved health in rural communities. There are many examples of rural healthcare innovation. Telehealth, community health workers, expanded scope of practice and task shifting, drones, new payment models, and leveraging strong trust in community leaders are all examples where lessons from rural innovation has helped fuel transformation throughout the healthcare system. My written testimony provides more examples of creative, local-based solutions. This kind of innovation that is responsive to the needs and assets of the community should be fostered and supported. History has shown that thoughtful legislation designed to address rural-specific challenges and leverage the assets of rural America has been successful in improving the lives of the 60 million rural Americans. Rural healthcare systems are different from urban systems, but they can produce similar or better health outcomes when given the opportunity. The pandemic exposed the fragility of our rural healthcare system. Fortunately, Congress has a number of policy opportunities to make real improvements in the health of rural America. Thank you.
Well, thank all 4 of you for your contribution to this hearing. Each of you have initiated plans in your own community to try to fill the gaps on access to care. So one of the questions I will be asking you, if we have time during this first round, is what tools at the federal level have helped you to implement that? And what additional tools would you like to see? Ms. Risch, you talked about and I've been to Choptank many times, the services you're providing are incredible, and you're right, your people are really dedicated to their mission. You talked about mobile facilities or school-based facilities. Senator Stabenow and I worked in regards to the lack of access for oral health care, and we use mobile and school-based as a way to fill that gap, and it worked pretty effectively. So what additional incentives do we need in order to provide that type of services in rural communities? Ms. Ani, you mentioned that some of your community does not have access to internet or even telephone service. How do we expand telehealth to rural America? Perhaps broadband is part of that, but how do we make that more effective, and what tools can we provide to make that work in your community? Dr. Herman, you talked about value-based. In Maryland, we have a total cost of care model, which is, I think, the ultimate in value-based. What other incentives do we need in order to allow you to move forward in those initiatives? So I guess my question to the panel, what would you like to see us do in order to help you fill? We can't fill in the rural community. You don't want us to do that. So the population is going to be sparse. What can we do to help preserve your unique way of life? When you deal with preventive health care and you deal with wellness, it's so difficult if you can't have a more presence in the community, particularly with older population that have challenges, more and more challenges. So just we'll go down the line. If you have programs that you think we can help you at the national level to meet your needs locally.
Yeah, so as far as telehealth goes, our community, a lot of them are aging populations, so they don't have the internet, phone, or computer. So that was part of our social determinants of health that one of the markers was high, was connectivity. So a lot of cell phone service we don't even have in the area if they're up north. So our patients are actually traveling down to our hospital to use our computer to access their telehealth in Billings. So maybe getting them computers or something, and then our telehealth in the rural health clinic is capped at a rate of, I believe, $98.24 around there. So those appointments aren't generating as much income either for us, but the connectivity issue would be something I think would be something to address.
And we did some of that in the bipartisan infrastructure bill, but we can look at as to how we could perhaps build that up more. Ms. Risch?
Well, thank you, Senator Cardin. So the school-based health centers are a powerful tool, and when we think about how we can improve health outcomes in rural areas, how can we reach people in different ways? And so we have a lot of tools in our toolbox to do that. The school-based health centers are very powerful, and in fact, one of the things that we've recently done was converted 2 of our school-based health centers, I shouldn't say converted, but expanded their reach. So 2 of them are now open to the community residents as a whole, so not just the school community, but the community around, because they are located a far distance from some of the other healthcare access points. So additional support funding for school-based health centers, mobile health units as well. There was a bill that recently passed to include mobile units as part of the new access point funding if there is some available for health centers. So moving that forward is great, but we haven't had new access point funding to bring more of those mobile health units to life. And then the other piece regarding telehealth, it was a lifeline. It still is a lifeline, but preserving the reimbursement for that, not only for the virtual visits, as we like to call them, but also the audio-only visits, because back to my colleague's point, having access to internet, broadband, et cetera, does provide some big obstacles for the communities that we serve. So sometimes that phone call and being able to talk to the patient and connect with the patient that way makes a huge difference.
And we have bipartisan legislation that would do that. Dr. Herman?
Thank you.
We believe that our patients really pay us in 3 types of currency. They pay us with their trust, they pay us with their time and attention, and they pay us certainly with money. The challenges of the distances across rural America have found, we find it necessary, rather than to have them come to us, we come to them. So we have community paramedic programs that actually help people with chronic management of their chronic diseases, post-acute care, and other things that really make a huge difference. Funding for those types of programs, as well as the training for the workforce that can support those types of programs, allows those patients to stay within their community and get their care. Doesn't need to be always with a doctor or be a nurse. And when you think about the economic cost that some of my colleagues have mentioned about having your son or your daughter take a day off work to drive you from Ely, Minnesota to Duluth, Minnesota for a 20-minute visit and then drive back, that could be better served by a community paramedic, is certainly a challenge for the family and a waste of America's economic vitality. So funding those programs where we can actually go to patients, whether it's through telehealth or the community paramedic program, can make a huge difference.
Dr. Holmes?
I'm going to build on Dr. Herman's comment there, which I think is really astute, and extend to home visits for maternal home visits and child home visits as well. But the appeal of all of these is that you're seeing how the population live in their own home, and understanding, they need a railing here, for example, if community paramedics can go there and avoid a fall. And so really understanding more about the treating health is just beyond healthcare and the whole complete package.
Thank you. Senator Daines?
Chairman, thank you. Ms. Ani, it's good to have somebody officially from the middle of nowhere. That was, by the way, determined by the Washington Post. And they had a criteria. You had to be 1,000 residents or more, furthest away from metro area. And the top 3 in the nation stacked rank were all in Northeast Montana. And by number 4, you went to Nevada, some small place. So you are literally from the middle of nowhere and have the gold medal. So we're glad you're here. I think you bring a very unique perspective, and I know your colleagues here who have shared similar testimony have similar challenges. In your testimony, you mentioned some of the notable characteristics of providing health care in these very rural and remote areas of the country, and I know when people are sitting in gridlock traffic, they're yearning to move to the middle of nowhere sometimes, and that's why we're seeing a lot of growth in a lot of parts of Montana. But we're seeing health professional workforce shortages across the board. Ms. Rich spoke about the acute challenges, the numbers you are facing right now in your facility. But these shortages have outsized effects when you're talking about rural communities where populations, the pool that you can hire from are limited, small to begin with. Could you speak a bit more to the rotating provider model that you implemented at your clinic, as well as your recent partnership with Intermountain to facilitate the behavioral health responses in the emergency room?
Yeah, so our rotating providers, that was an organization that we luckily found because we were having, we lost our orthopedic surgeon, and if we don't have that, patients have to drive 300 miles, to have a hip or knee replaced, so we felt that was a critical need. So it is 24/7 coverage. We have 3 full-time providers that rotate in. They live elsewhere in the United States, and they fly in for their rotation. They do a 10 to 12-day rotation, and they're on call 24/7. They run a clinic, and then they do surgery. And that model worked so well that we achieved that for general surgery, and then OBGYN as well. And then we just, unfortunately, our radiologist is moving, so we are possibly looking for that model for radiology.
Dr. Herman, thanks for your testimony and highlighting the Essentia Health's work serving rural communities. My ancestors that came from Norway stopped in Minnesota for a while. Then they heard the mosquitoes were smaller out west, so I think they kept going. You've had some of the most successes in Minnesota, but there are others that are interested, I know, in adopting similar approaches as well. So maybe for us here in this, as senators, and for those of us listening to this hearing, what are some observations and best practices that you see that have worked to drive your success? What are some of the barriers you've had in the process of trying to implement value-based care, as you mentioned in your testimony, in more rural areas?
The challenge that small providers have is the challenge of scale. It's hard to build the infrastructure to support a value-based program when you have 2 or 3 providers in a small community. Essentia Health is a conglomeration of more than 30 different practices across northern Minnesota, Wisconsin, and North Dakota that got together because we have a common mission, and that's to serve our patients better. I think the federal government could provide support for, just like when we live in rural areas, we're very familiar with the cooperative model. There's no particular farmer in a small community that can own his or her own silo. But if you can get together and provide that infrastructure, whether it's the IT infrastructure or the care infrastructure, you're much better able to do that. I also think that some value-based programs are rightly very concerned about the outcomes, but when you are in a small community, you are a slave to the law of small numbers. For many of those communities, the process is more important than the outcomes. So if you're measuring the cost of care in a small community, one patient with breast cancer can certainly raise the cost of care, and you end up missing your targets. Mm-hmm. So how do you get the right process measures to support that particular type of care, and pulling it together with the infrastructure that can support not just a large healthcare system, but could support many small healthcare systems?
So here's that. Do you get, is there sympathy to your argument in terms of, since the pool is so much smaller, right, where you could have one particular patient could drive means and so forth out of whack? Right. How do you deal with that?
Yeah, measurement matters. So what are the things that you're doing that get your average patient healthier? The advantage of those small numbers is you can take a look at almost every patient, particularly if you have an electronic health record supporting that. Mm-hmm. It also allows you to get a fine view of the social determinants of health, and what does the community need other than a healthcare provider to support some of the care of the members of their community. If you're living in a food desert and people are eating high-salt foods, the chances of them being rehospitalized for congestive heart failure is very, very high. So rather than just taking a look at the patient's path from illness to wellness, what's the patient's path to sustain themselves after they get that? And that's building the community.
Thanks, Dr. Herman. Mr. Chairman.
Senator Stabenow.
Well, thank you very much, Mr. Chairman and Ranking Member. This is such an important hearing, and thank you to all of you for coming. And I specifically have to say, Ms. Rich, coming from Western Michigan University in Kalamazoo, it's so great that you went to school there. And I understand that Dr. Holmes, you went to school at Michigan State, is that right? Go Green. Okay, that's great. In Carroll, Michigan, I know well. Very beautiful place. So tell your family hello. All of these issues are so important. I grew up in Clare, in the middle of the state, northern Michigan, and my mom was director of nursing at a small hospital. And my first job was at the hospital. This is how old I am. My job was cleaning the test tubes in the lab in the basement after school. They just throw them away now, so I know. But so that was a long time ago. But I grew up around healthcare and rural healthcare. And so very much appreciate this. There's so many pieces to this, both physical health care, behavioral health care. We've done a lot together to increase community behavioral health clinic access, and I know representing states that include that now through Medicaid funding, and others that are applying in Montana and North Carolina and so on, to be able to move forward. But I wanted to zero in for a minute on school-based health centers, Ms. Rich, and talk a little bit more about that, because so many times children are getting access to health care or behavioral health care through school. That's where it is. And so this becomes so important. I'm leading an effort with Senator Capito, a bipartisan effort on school-based health care, both funding. We got first-time funding line item in the budget last year, but we have hallways to health care where we're trying to, as I'm sure you're aware, increase both children's health insurance funding, Medicaid funding, working with our health centers, working with behavioral health centers to get into schools. And we also made some good progress with significant funding as part of the gun safety legislation on school-based health clinic grants and behavioral health and so on. Could you talk a little bit more? You mentioned that your school-based healthcare program cares for thousands of patients. Could you talk a little bit more about how accessing comprehensive care right at school expands access both for children and for families?
Well, thank you so much for the question, Senator Stabenow. And I also had wanted to add, I also went to Michigan State. So
oh, you did go to Michigan State?
I just wanted to add
you went
that.
To two schools
yes.
in Michigan. Oh, good.
So, my apologies.
Yes.
You can't let that go as a Spartan.
That's right.
But school-based health centers are such a wonderful way to provide access to care for our children. When children are in pain, whether it's from a dental infection or they have strep throat, they're just not feeling well because maybe something happened with some friends and they're feeling down. Having that access in the school makes all the difference, and especially for those of us who live in rural areas. I've used our school-based health centers, and often parents work out of county, for example. They may work 30 or 40 miles away from where their child goes to school. And so having that peace of mind and knowing that there's a trusted healthcare provider, whether it's dental, behavioral health, or medical, is such a relief for families that they're going to get what they need while they are in school. We can do lab testing in school. We can take care of acute needs. We can help with chronic conditions such as asthma in school, with dental infections and abscesses, connecting those children with additional services and care that they need. So it is just a lifeline for many of these children in the communities. And if you're not healthy, you can't pay attention in your math class. You know, you're not going to be able to write an essay. And so having that access is a huge relief for the students, for the school team as well, because they want to have healthy students so they can be healthy learners, and then certainly for families in the community. So I'm excited to hear about the work that you are doing to enhance and expand school-based health centers across the country. It is a great tool for accessing health care in rural areas and certainly beyond.
Great, thank you very
Thank
much.
you.
And one more question for
Yes.
you, which Senator Daines and I have led a bipartisan working group in the Finance Committee on workforce related to behavioral health.
Okay.
And we were able to have some things happen, some additional GME slots for psychiatrists, specifically to be able to do some things around Medicare coverage last time, which was helpful. But one of the things that didn't happen that we had put in our recommendations was talking about how to increase the workforce by adding a physician bonus payment in shortage areas and allowing non-physician providers to also receive a bonus payment if they're going into underserved areas. We do have some of that on school loan, forgiveness and so on. But if we were to add a physician bonus payment for rural areas or for other non-physician providers, you mentioned that your clinic is in a mental health shortage area. Mm-hmm. And so I'm wondering how a bonus payment could help clinics like yours attract and retain more providers.
No, thank you for the question. I think that anything that we can do to help and retain providers in our rural areas, especially for behavioral health, is something we need to take very seriously. We do have a lot of National Health Service Corps providers in our organization, and it's a wonderful recruiting tool. We need to work hard when providers come to our area to connect them, to help them be part of the community, because once they come, we want them to stay. And so how do we do that? And that might be a way, in terms of that bonus payment, when your service is done with National Health Service Corps, maybe there's an additional payment to, continue that service. So I look forward to hearing more about that. Thank you.
Thank you, Mr. Chairman. Sorry, I'm over time. Thank you.
Oh.
Senator Blackburn.
Thank you, Mr. Chairman, and thank you to each of you for being here. I represent Tennessee, and as you all know, Nashville is the center of much of healthcare in this country, and managing hospitals, and of course many of our companies and our citizens are employed by companies that manage rural hospitals. And in Tennessee, 50% of Tennesseans are in a rural area. So we pay quite a bit of attention to what is happening with access to rural health care. And we do what we can to increase that access. And in my work as co-chair of the Rural Health Caucus here in the Senate, we spend a good bit of time looking at that. When I was in the House, I came up with legislation for telehealth. And nobody was interested in telehealth until COVID hit. And then all of a sudden, everybody was saying, let's get that bill and pass that bill. And of course, it went in under the emergency health order. And I've worked with Senator Crapo to try to decouple that so that we can continue with telehealth. In the behavioral health arena, it makes a tremendous difference. When I'm talking to our community health centers, it makes a tremendous difference. And we have one county in Tennessee, Hardeman County Community Health Center, which has access to a cardiologist through e-consults and ConforMed. Now, they've never had that access in this county, but now they do, and it is showing tremendous gains and benefit into this service area. So, Ms. Rich, let me just stay with you. If you would talk about very quickly how you all have used telehealth, and then why parity in that payment is important for telehealth.
Well, thank you for the question, Senator Blackburn. And certainly, telehealth was something we knew that we needed to implement. And certainly with the COVID pandemic, we implemented it basically overnight and needed to do so if we wanted to provide care to our patients. So telehealth has allowed us to reach our patients when they couldn't come into our health centers during the pandemic. But certainly now, it is another tool in the toolbox to be able to provide access to care. And it's wonderful because we have patients that have transportation issues. They live long distances from the health center. And again, it's another way for them to access care. In terms of reimbursement parity, I think that's going to be really critical as we move forward. It has become integrated into service delivery models at our health center, at other health centers, and patients need it.
Yes,
Patients
they
want
do
it.
need it. I have a rural health care agenda that I've worked on for the last 3 years. Senator Durbin and I have a bill that focuses on workforce and would incent even further than the National Health Corps, getting people into rural areas, healthcare professionals. Also, a component of it is on innovation in delivery of care, and the third component is something Senator Warner and I are working on for an appropriate national minimum to address the area wage index. And we think that that is important. You're not going to get innovation in rural health care without these things. And we think that it is so important. We're concerned about the closure of rural hospitals. Dr. Herman, I'd like to ask you about that. If you all are looking at this and then the way the community health centers are coming in and helping fill that void because we are facing closures.
We believe that no rural hospital should have to stand on it by itself. And I think many of the ones that are closing are hospitals that have had to stand by themselves. So we have hospitals within our system that if they were not part of a system would not be able to stand by themselves. But providing that integrated care that surrounds it, having whether it's a health system or another entity take responsibility for the care in the area, not just a particular community, I think makes a tremendous difference. From a telehealth standpoint, one of the challenges that we have is that we certainly don't want anyone to practice fraud from a telehealth standpoint, but I use the bird feeder analogy. Sometimes you're so concerned about keeping the squirrels out of the bird feeder that the birds can't get in either. And I think when we start looking at some of the regulations we're building around telehealth, sometimes it really impedes the provider's ability to care for a particular patient.
Thank you for that. I know I'm over time, but I am working on community health care access for veterans. And one of the components that we are working on right now is allowing these veterans to immediately access care in their local community. And just a thumbs up or thumbs down, would your facilities be able to handle veterans coming in, showing their card, getting that health care, and then our responsibility would be making certain that there is a way for you to bill that back quickly and, of course, be quickly paid, not 180 days out, right? Absolutely. Thank you.
Senator Cortez Masto.
Thank you. Coming from Nevada, telehealth is key for our rural communities as well. I'm curious if anybody is opposed to audio-only visits as well.
I'm very much in favor of audio-only visits.
Right, because a lot of areas do not have the broadband capability to have anything other than an audio visit.
That's right, and that's why we really should be pushing both of those together, and we can address the fraud concerns always. Let me jump to another issue I'm hearing from our providers in Nevada. They're experiencing challenges contracting with Medicare Advantage. And clearly, as we have more and more beneficiaries choosing to enroll in Medicare Advantage, we want to make sure that we take a look at this relationship between the plan coverage and the patient access. Ms. Ani, let me ask you this. How do Medicare Advantage payments for rural health clinics differ from traditional Medicare? And do these payment differentials, if they do occur, really create access issues in rural areas?
Yeah, so our facility, we don't take advantage of we're not contracted with the Medicare Advantage, but For our other rural health clinics, there's been a drastic increase in the Medicare Advantage enrollment, and it threatens the rural health safety net. So while rural health clinics receive enhanced traditional Medicare payments in comparison with their fee-for-service, their counterpart says Congress recognized the increased costs of providing care in rural America and the high value of care in these communities. So there's no statutory requirement around RHC Medicare Advantage reimbursement. With that, oftentimes, there's less negotiating power as one of few providers in a rural area. So many RHCs across the county are facing the financial stability concerns due to the low Medicare Advantage reimbursement rate.
And is that what you guys are seeing?
Reimbursement's different.
Thank you. And is everybody else seeing the same thing?
Yes, and prior authorization becomes a challenge with some Medicare Advantage plans as well. If you've come 200 miles and you're at the clinic and you can get that service right now, and then your Medicare Advantage plan says, well, we need to take another 2 weeks to take a look at this. Even when they do say yes, you've gone back 200 miles and you got to come back another 200 miles and go back another 200 miles.
Yeah, and let me just add to this, because I appreciate Senator Daines and your comments in northeastern Montana. Elko, Nevada, it takes 4 hours to get to a medical facility either in Salt Lake or into Reno, Nevada. And so we see this, similar concerns about how we address healthcare and bring that healthcare to our communities. So Dr. Herman, I'm really interested in this tri-state cooperative that you have. And you talked about it, obviously the value-based payment strategy, but you also talked about shared IT and community partnership programs. How did you get that up and going? How did that start?
First of all, you have to build the relationships and you have to build the trust. But we are on the Epic platform, and we have our Epic platform in hospitals that are not our hospitals. But we have the clinic within that community. If we have a different healthcare record, we don't know enough about our patients to be able to take good care of them. So literally putting that healthcare record within hospitals that we don't own or within clinics we don't own helps the population that we're all privileged to serve by coordinating that care.
And let me ask you this. Just in 2020, Congress created a new designation for rural hospitals, the rural emergency hospitals, and it went into effect January of this year. I know it's still being rolled out, but what's unique about rural emergency hospital designation that make it an attractive option? Is it an attractive option for rural providers?
We're still taking a look at that. We'd like to thank Senator Grassley and the rest of the Senate for the great work that they did on that. One of the advantages of that program is you don't have to have an inpatient part of your hospital. You can move it to an outpatient and still be able to qualify for funding that supports the hospital within that. We are fortunate enough within our thing that those beds are really needed, even with the 96-hour rule, which we could talk about some other time as well, because we've seen an expansion of the ability for these hospitals to care for patients through the pandemic. But for a place that doesn't have the need for that inpatient care, but needs something within the community, we think it's a very constructive model.
Thank you. And then finally, we talked a little bit about the mobile health units. The Mobile Health Care Act was passed. Are there any impediments that you are seeing that we need to address after the implementation of this law?
Well, I know it's a fairly new law.
Right.
Thank you for the question. I think it has a lot of opportunity for community health centers to expand that access and take mobile health units on the road. I think the challenge with it is it goes along with new access point funding that would be available to health centers, and there hasn't been new access point funding in a number of years.
Okay, thank you.
Thank you.
Senator Grassley.
Yes, I'm going to ask Dr. Holmes, but let me lead in with this. I've helped pass the Voluntary Rural Emergency Hospital Program, and I thank the senator from Nevada for bringing this up. Since January, several hospitals have become rural emergency hospitals. An article from St. Mark's Medical Center in LaGrange, Texas, was titled, quote, Texas Hospital to Keep Doors Open with Rural Emergency Hospital Designation. Another article about the Holly Springs, Mississippi hospital quoted a hospital official saying, quote, we expect the new designation to improve both the financial and the outpatient capability for citizens of Marshall County. There are several more examples. So Dr. Holmes, what hospitals are prime candidates to become rural emergency hospitals, and what would be the alternative for hospitals if a rural emergency hospital didn't exist?
Well, the alternative is, for many of them, closure. And so at least the REH program offers them an opportunity to provide emergency department care to their community. That's usually one of the first instances that we notice when a hospital closes is someone needs an ED service, and within 3-4 days, it's not there during a closure. Dr. Herman, I think, touched the main points for which hospitals would be strong candidates for REH conversion. These would be places that have low inpatient use, probably a low ED volume as well, and have been financially struggling.
For you and Dr. Herman, I support the Rural Community Hospital Demonstration Program. It's a key tool to support rural hospitals and maintain access. Currently, the Centers for Medicare and Medicaid Services is underutilizing the program by leaving 5 of its 30 spots open. So do you think that we should be underutilizing a cost-effective rural hospital program like Rural Community Hospital Demonstration?
Certainly not. Certainly the need is there. I think what we would need to do is go back and take a look and say, why haven't 5 other hospitals put into that? Sometimes the regulatory hurdles are so complex that they're either hard to understand, or if there's 20, you can meet 19 of the 20 requirements and you can't meet that last one. My suggestion would be have an outreach program from CMS to many of these rural hospitals and try to facilitate the application rather than just sending it out.
You got anything to add, Doctor?
I do not. That's a great answer.
Then let me go to you two again. I have championed efforts to ensure Iowa physicians get paid fairly for the health care services that they do. Iowans pay the same amount of money on Medicare as everyone else in the country, yet rural states like Iowa get shortchanged when Medicare pays Iowa physicians less than a lot of other states, and I'll use New York and California as an example. Lower reimbursement has several impacts, influencing physician practicing in our state. The labor shortage of physicians is not local but national, especially in the age of telehealth. There are many unforeseen costs of physicians face by working in rural areas, namely travel time, transportation costs, and broadband. Congress has established this geographic practice cost index that we call around this town as GYPSY. That floor is to ensure rural state physicians receive fair reimbursement. At the end of 2023, this is going to sunset. How does the GYPSY floor protect access to physicians in rural areas?
I'll take that one first, I guess, and you can build on it. I think an important thing to remember about where the GYPSY comes from is it's based on historical and longstanding patterns, prior to its introduction. So a state that has low wages gets a lower GYPSY, which means lower revenue, which means they pay lower wages. So there's a cycle there that's sort of self-fulfilling, and I think we've seen some examples where CMS in particular has tried to up some of those price indexes, and it'll be interesting to see what kind of impact that's had.
Do you have anything to add to that?
Yes, I would say that it used to be in the 1960s when you evaluated a physician's standard of care, it was based upon the community. Now a physician's standard of care is based upon the broader community of the United States. Their health care costs to run a practice are much more reflective of the broader healthcare costs across the United States than something that happens in Osage, Iowa. So I think there needs to be something done with that.
Thank you, Mr. Chairman.
Thank you. When Senator Lankford came in, he actually bumped Senator Grassley, but I didn't know that. So let me defer now to Senator Lankford, and then I'll pick up after him.
No one on our side of the aisle bumped Senator Grassley. So just for the record on that, let me add one other comment here, what Senator Grassley was talking about on the GYPSY issues and the reimbursement for physicians. When Oklahoma is competing with New York City for rates and cardiologists, the devices cost the same no matter where you are. The costs of everything are the same. And so this process of punishing doctors if they practice in rural America or even in just not in the largest cities in America, has got to be resolved in this long term. Shockingly to some folks outside this building, there are some areas that we can work together. Last week, Senator Durbin and I actually dropped a bill on Rural Hospital Closure Relief Act. It's the same bill that we actually had in the last session that we felt we were very close to dealing with. And this deals with the critical access hospital designation. The rural emergency designation doesn't work for every location, and we are trying to fix this 35-mile perimeter that we literally have hospitals in Oklahoma that are 34 and a half miles, and trying to be able to work through the process, and it become a pain on it. So there are areas where we're trying to work together practically to be able to resolve some of these in very practical ways on this. Oklahoma State University has had a process for a while of trying to attract people out of rural Oklahoma so that they would return to rural Oklahoma to be able to practice medicine. OU has been very aggressive in trying to be able to train physicians as well, nurses, other practitioners. So there is some practical work that's ongoing on this, but clearly we have a long way to go in several areas on this. I do want to talk about some of the workforce issues because this is a significant issue in attracting workforce into rural hospitals. Duncan Regional Hospital in my state has done a lot of work in partnering with local universities, even reaching into high schools, doing programs there, and then helping them through their education to be able to then return back to Duncan Regional on that. Have you seen success, and any of you can answer this, have you seen success like that in other areas? Because that's been very successful for Duncan Regional. Anyone else seen success in recruiting workforce long-term?
Yes, thank you for the question, Senator. I would say that partnering with universities, academic medical centers has helped us a great deal in providing greater access to health care in rural areas. We have a partnership with NYU Langone for general dentistry residents. We are working to establish another residency for pediatric dental care, and we are working with the University of Maryland School of Medicine to establish a rural training track for physicians in the area. I think what the challenge is that some of these initiatives that we've taken on, they take time. And you have to be proactive to plan and to get them into place. And I think right now in terms of workforce, we're in two stages. We're in reactive and proactive. And so how do we bring all those together so we can address these challenges?
Yeah, it takes a while to be able to raise it up. The federally qualified health centers in my state, we have a phenomenal group of leaders and groups that are doing it, almost 200 in my state, scattered around the state. They are the primary caretaker for a very large percentage of so many folks in our state, and it's been a very, very successful model now for several decades. So very grateful for them. They've raised the issue to me about 340B, and I know that's not in our committee, but for contract pharmacies. Are you dealing with the contract pharmacy issue, Mrs. Risch? The federally qualified health center and trying to be able to deal with that pricing model? Is that something you're dealing with right now?
Yes, many community health centers across the country are 340B participants, and it certainly is an important tool that we have to assist our patients and provide additional care in rural areas.
That's been a big issue on the pharmacy side of this as well. This has been one of my frustrations, and I know none of you are pharmacists in that sense, but you're interacting with those folks. In a lot of our rural settings, that local pharmacy in many areas is the only really healthcare professional that's in that area. I have a lot of concerns. Our committee's talked about this quite a bit. I'm going to continue to be able to raise the issue of the DIR fees, especially for our rural pharmacists and those independent pharmacists. Literally, PBMs are driving our rural pharmacies out of business for their benefit, but not to the benefit of healthcare advice for many of these folks in rural areas to be able to come to someone and just saying, hey, just mail order this and it's going to be fine. But that's not fine for a lot of folks that just need some counsel, that have multiple medications and need somebody to be able to talk to. Are any of y'all dealing with individual pharmacies and the DIR fees in particular?
One of the things that concerns us, particularly for rural health care, are white bagging, where as an example, chemotherapy is provided in a small community, but the insurance company makes sure that they get the medication from the insurance company rather than from the local care provider. What people don't understand is that some of the money that comes from getting that medication at that particular area pays for the care and the infusion center that the patient is getting, particularly in a rural area like Deer River, Minnesota. When that goes away and white bagging goes away, that site goes away because there's no way to fund the site.
Yeah. Mr. Chairman, I appreciate you holding this hearing and going through this incredibly important issue for us. I'd love to be able to spend some time, I'm out of time on this, but the issue about Medicare Advantage, We have quite a few Medicare Advantage carriers that are advertising to rural America to get Medicare Advantage. People are signing up for it and finding out that there aren't actually providers in their area, and they have to travel in very long distances. That's a different conversation for a different day, but that's definitely affecting rural America as well.
It's a conversation we need to have because we've also had Medicare Advantage plans leave some of our rural areas without much notice. Senator Whitehouse.
Thanks very much, Chairman, and thank you to this panel. We don't have as much rural going on in Rhode Island as many of these states, but I very much appreciate the work that you all have done. And I'm particularly interested in what Dr. Herman, you think about the ACO model. I worked very hard to get that into the Obamacare bill. I have been a harasser and shepherd of it as CMS people have tried various, I thought, not particularly helpful things to strip revenues out of ACOs as soon as they get them and set the new standard low so that you're competing against yourself in ways that are ultimately fruitless. And I'd love to hear from you if there's anything that you think is immediate that would help advance the ACO program, and to the extent you want to reflect on it, if you could take that as a question for the record, because I'm eager to spread ACO incentives as broadly as possible and to try to make sure that in Rhode Island we had 2 spectacular ACOs. I mean, killer. They were just fabulous. They made a ton of money for Medicare. Their patients just love them. So I've seen it at its best, and I want to make sure that that gets
We are strong proponents and strong practitioners of value-based care in the ACO model. We were probably one of the only level 3 ACOs in rural America. We believe it's the best way to care for patients. I agree that when you look at the Medicare Shared Savings Program, my colleague Dr. Holmes is a mathematician, but if you integrate that over time with the model with the Shared Savings Program, somewhere along the line you're giving perfect care free. So the question becomes, what's the floor on that, and what's a reasonable amount to do that? There are many different ways to set up these programs. I think a lot of the programs are set up without the knowledge of the people that they serve, particularly from the regulatory side. And what I would suggest is that you partner with people that want to do it, have a commitment to do it, and do it well, and see how they do it. And then work with colleagues like Dr. Holm and Ms. Rich and Ms. Ani, who are really committed to providing great care for their patients, because it is a great model, not just in rural America, but any place in America, because it takes really 3 things. You know who your patients are, you know what they need, and then you can get it to them before they really need it. That promotes health, wellness, and well-being, and it also decreases the cost of care.
Well, I still have scars from years of engagement with CMS on this subject, and I hope they have a few too. And I think we've learned to respect one another, and I would love to work with you going forward. So let's stay on this.
Perfect, thank you.
Ms. Rich, you are in the Maryland Primary Care Program, which is a statewide program that we don't have. I think it's unique to Maryland. So I'd really like to get your take on how that works. One of the things that I think bedevils the healthcare system we've talked about is the burden of prior authorizations, claims denials, payment delays, the payment warfare that takes place between payers and providers, which at the end of the day I think is a net loss to the system. It doesn't actually add value. If it does, it's negligible, but I think it's actually negative. It just eats up cost and time and effort. Once you go to the Maryland model and you get away from fee-for-service, which I think encourages those kinds of behavior, have you seen that architecture of obstruction diminish in your company or in the state generally?
Well, so I want to start out by saying the Maryland Primary Care Program certainly is under the Maryland Total Cost of Care model that really focused in on hospitals. And so primary care components came in about 2019 and following the community health centers. Chop Tank just joined the Maryland Primary Care Program in January, so I don't.
So you're still in the beginning process.
We are. So I don't have a lot of experience to speak to it, but I'm very excited about the transformation that it'll be doing in our health center to provide greater access to services to wrap around our patients and work on healthier outcomes as a whole.
Well, to me, it stands to reason, and I've got 30 seconds left, so let me make this a question for the record to any of you who care to engage. It strikes me that this whole claims denial measures, claims pursuit countermeasures, that whole back and forth is completely unhelpful and very expensive, and ultimately, I think, bad for patients. And to the extent that we can get off of the fee-for-service model that encourages it, I think that's likely to diminish, which will be good for the cost in the system, good for patients, good for providers, good for everybody. So if anybody has observations on that point, in addition to what we should do to help ACOs, I'm all ears, and I look forward to hearing from you. Thank you.
Senator Whitehouse, let me just point out the Maryland total cost of care model is really very much what you want to see. You reward the overall health care cost of an individual rather than stovepiping the different types of needs. And it's also an all-payer rate structure so that you're not rewarded by having private pay versus Medicare or Medicaid. They all pay the same rates at the hospital. So it is a system that's rather pure in that regard. Senator Casey, you get total 5 minutes. Those 29 seconds are held against you.
Mr. Chairman, thanks very much. Thanks for having this hearing. I just have one question in the interest of time for Dr. Holmes, but I wanted to start by just laying a little bit of the groundwork for the question. I live in a state that has 67 counties and 48 are rural, and the primacy of rural hospitals in so many counties can't be overstated in terms of healthcare access, the good quality of care they provide, as well as the job base that they provide. And Dr. Holmes, you said in your testimony that since 2005, I guess it's a little more than 190 rural hospitals have closed, about 193, I guess it is, and I'm told that 150 of those are just since 2010. It's hard to comprehend the scale of that. I guess some continue to provide healthcare services, but roughly half of them don't provide healthcare services. These closures lead to a decrease in the labor force and the population living in a community. I've seen that in Pennsylvania, and as I said, are so important to the stability of a community. I pushed for a 2-year extension of the enhanced payments for the Medicare dependent and low-volume Medicare hospital adjustment payments in the so-called omnibus, the appropriations bill last December, I should say. And I'm proud to reintroduce a bill with Senator Grassley to make both of these payment adjustments permanent in order to provide certainty surrounding the funding for these hospitals, including 27 of which are in the state of Pennsylvania. Dr. Holmes, can you speak to how permanent funding, such as Medicare-dependent hospital, the Medicare-dependent hospital program, and the enhanced low-volume Medicare adjustment payments would provide predictable funding and help protect the financial solvency of rural hospitals?
Yeah, thank you for the question. I think this kind of goes back to the question that Senator Grassley asked as well about RCHs, in that you're asking hospitals to, move to a new program or to make decisions about investments on something that might be here in 2 years, might not, and let's face it, MDH and SCH have been continuously extended, and so while it's fair to believe that it probably will keep being extended, you're asking executives and administrators to make decisions on something that looks like will end. So I think a permanent decision or a permanent extension of these programs will be beneficial. It'll allow them to have certainty and make investments rather than looking at, well, we can't do too much because we don't know what it's going to look like in the next year or two, to really say, all right, we think this program is permanent. We can make decisions planning on having a certain revenue flow.
Doctor, thanks, and I want to thank the panel as well. I've got to run, but thank you, Mr. Chairman.
Thank you. Senator Carper.
How many counties do you have?
67.
And how many are rural?
48.
We only have 3 counties, and 2 out of the 3 are rural, and the other aspires to be, but probably without success.
Those 3 used to be in Pennsylvania.
It used to be in Pennsylvania. That's okay. That's we know who the first state is. It's Delaware. So, question, if I can, do you pronounce your name Mish Rish? R-I-C-H? Rish? like R-E-E-C-H, right? We have a colleague from Idaho who doesn't know how to pronounce his name either. He spells it the same way. So I have a question. I want to start off with you, if I may. We're grateful that you're all here. Dealing with federally qualified community health centers as with respect to increasing access to behavioral health care. I'm a huge proponent, have been ever since I was governor, even before I was governor. Huge supporter of federally qualified community health centers. We have them in each of our counties, and they do wonderful work in a variety of ways. But I call them federally qualified community health centers. I don't even use the acronym, but I always have. But they play a critical role in our state. And increasing access to care. My notes here say to everyone, not to everyone, but to a whole lot of people. And we are, and that's particularly in rural communities, but not entirely, not entirely. There are many rural communities in the state of Delaware, and I'm proud to serve as co-chair of something of we call the Senate Community Health Centers Caucus that you may have heard of, along with my fellow co-chairs. Listen to this: Senator Cardin, Senator Cornyn, Senator Cassidy, and Senator Carper. What is similar to all those people is the letter C. The letter C, there you go. I like to say the letter C defines, tells people, that secrets to a happy marriage, communicate and compromise. But also, that the letter C can be used to apply to getting things done here in the Senate. And the four names I've just mentioned are people who like each other, we're bipartisan, bicameral, and we get a lot done. But the services provided by federally qualified community health centers go beyond one's physical health. They also provide crucial services, as you know, for mental health care and treatment, not only in Delaware, but in the other 49 states as well. I oftentimes say, as Ms. Senator Cardin will attest, find out what works, do more of that. I used that just this morning in a hearing on permitting processes, but find out what works, do more of that. In that spirit, Ms. Reish, could you just share with us some of the best practices from centers that are doing an especially good job providing mental health services and addressing behavioral health needs of rural communities so that the rest of us can learn from their success? Find out what works, do more of that. Go ahead.
Well, thank you so much for the question, and thank you for your support of community health centers. So we have just implemented behavioral health at our health center about 2 years ago.
Where, again, tell me again, where is your health center?
Eastern Shore of Maryland, so Caroline County is our headquarters. Okay. And, you know, when we think about our mission, providing that access to the comprehensive care that's integrated, you know, not providing that behavioral health service was a barrier for our patients. And so bringing behavioral health into the health center was very important because we ensured that it was integrated with primary care. And so through the course of the patient care day, if one of our medical providers was treating a patient and did some of the screening tools that we use, the ESPERT screening for substance use disorder, depression screenings, et cetera, we connect the patient with a behavioral health therapist right then and there through a warm transfer. And so what we have found with that warm transfer process is the patient is in a place where they're ready to get into treatment. They likely show up for their appointments, and they are getting better. And that's what we want to do. Also take away some of the stigma, too, that the behavioral health is right there co-located with our medical, with our dental as well. So I think that integration is really key, and then ensuring that we do those warm transfers as well during the course of the visit. So that's some of our lessons learned as we've moved forward with behavioral health care at Chop Tank.
Well, that's good. I have about 30 more seconds. That's probably not enough time to ask another question, so I'll just sit back and listen to Senator Barrasso, Dr. Barrasso's question.
But do you have any Delaware patients that come into your facilities?
Yes.
I thought Senator Carper would like to know that.
I would like to know that.
Senator Barrasso.
Thanks very much, Mr. Chairman. Dr. Holmes, if I could, for over 20 years, I practiced as an orthopedic surgeon in Wyoming, a state where we are always trying to recruit and retain physicians in rural areas, sometimes pretty remote, to just get the health care that we need. I think we're running more and more into the fact of recruitment being a challenge, especially since so many residency programs for training are done in the big cities. And you know the correlation of where people more likely to then set up a household where they decide to live and practice based on where they trained or within a radius of 50 miles from there. So I see that as a disadvantage to rural communities because the training is from a distance. So Senator Tester and I have a bipartisan bill called the Rural Physician Workforce Production Act of 2023. It addresses the current Medicare-funded residency program problem for entire states. And the bill would solve some problems by lifting resident caps and removing Medicare limits on rural resident training growth, providing equal funding to rural hospitals for residency training because so much of that funding is disproportionate, increasing Medicare reimbursements for urban hospitals that send residents to rural health care facilities, and creating an elective per resident payment initiative to ensure rural hospitals have the resources to bring on additional residents. So the approach to solving workforce shortages, empower rural healthcare providers, I think it's something we should try to implement. So can you explain how legislation geared toward rural physician workforce development could impact health outcomes and access in rural America?
Great. Thank you for the question. I'm glad you brought this up. As you mentioned, we know that two of the strongest predictors for rural practice are being from a rural area and being trained in a rural area. And so addressing the paucity of physician training, but also more generally workforce training in rural areas is critical. Rural areas have shortages, and so of just about every workforce, and so a initiative to boost training in rural areas has twofold effect. The first is in the short run, you have trainees out there providing better, more care, but also in the long run, you're going to generate a workforce that is more rural aware and likely to continue to practice.
And then, Dr. Herman, in terms of the local community hospitals, nursing homes, in a place like Wyoming, if there's a loss of one facility, the impact on the entire community can be devastating. Not only do closures impact the services and the care provided, it imposes additional challenges in terms of attracting teachers to the community, attracting small businesses to the community, all of those sorts of things. Recently, the Wyoming Hospital Association conducted a statewide study to determine the economic impacts of hospitals and nursing homes, and so it's very significant, the number of jobs that are supported. So what do you see federal policies that you think are most needed to protect against closures of these critical facilities in rural areas? Because I think over the last 15 years, whether it's a Republican administration, a Democrat administration, the great number of hospital facilities that closed are rural.
That's right, and I think you said it's on one facility. It can be one person that causes one facility to close. So I think Dr. Holmes addressed a lot of that. One thing that we've found successful in recruiting providers to rural communities and retaining them, that it's not the health system that recruits and retains the providers, it's the community that recruits and retains the providers. So we get our communities very involved in the recruitment, the retention. When you're part of a community and you recognize that you are a very critical part of the community, I think it's very gratifying as a provider. I think you're much more likely to come and you're much more likely to stay.
Yeah. So, Ms. Ani, following that, so we had a community in Wyoming a number of years ago when I first started to practice where we had a physician and a physician assistant. At the time, they were tied together where the physician had to observe and be in the same facility. So the physician was tragically killed in an accident. He was the only physician in a community. And at that point, there was no way for the physician assistant. The community tried to recruit a physician to then supervise the physician assistant. So they were going to lose everything. Well, we actually were able to change the law in Wyoming to then have the physician assistant report and work under a physician at a remote location in a local hospital, in an emergency room 100 miles down the road. Not as ideal, so it reflected a need that was going to be met, and legislatively we stepped in. Have you seen similar things to that where legislation has to be done at a local level or statewide to try to help put health care in communities?
I don't have anything to answer towards that. We do have PAs and nurse practitioners in our facility, which is great, but I don't have anything that's legislative.
Because I don't know, Dr. Herman or Dr. Holmes, you've seen a change in how physician and physician assistants, nurse practitioners, additional care providers has evolved since kind of our days in medical school, if you will.
We have advanced providers that actually staff some of the emergency rooms in our smaller hospitals, supported by the physicians in our Level 1 Trauma Center, and also transportation from the people there. So I think it's a very good model that can be done. I think it does have some limitations. You're probably not going to get an emergency trained physician in every small community, but we have a lot of resources that sometimes regulations get in the way. What we can certainly do is get back to you on that, because we can look at the regulations and say where the barriers are.
Yeah, because we're seeing some, yeah, Dr. Holmes.
Just that it recognizes team-based healthcare, which I think is where we need to be headed. Yeah.
Thank you, Mr. Chairman.
So, Ani, you mentioned transportation as being one of the challenges. Do you have transportation available for those who need it in your community? And if you do, how is it financed? If you don't, what's your recommendations for filling this void?
So currently, we are working on a transportation project within the hospital and the community. We don't have hospital-based transportation that we have at our hospital to bring patients to their appointments, but we do have a county transit, and so we're working together with the transit on marketing them and help patient awareness, and then asking patients when they do call to make an appointment if they have transportation needs, and then hooking them up with that transportation service so they're aware of it, because I think a lot of people aren't aware, but we do have huge transportation needs. So also collaborating with the tribes on how to get those patients over to our community, because we do have a lot of people in our area that either don't have a ride either to their appointments or to outpatient surgeries, or even like I had mentioned before, when they come to the ER, they don't have a ride home. So we are working on our transportation efforts and trying to come up with a system. So we have different phased approaches to that, how we're going to come up with that.
Ms. Ridge, I know some of our local governments are providing some of the needs, I know, on the Eastern Shore on transportation. Let me ask you about patients that have chronic conditions and need regular follow-up care. If they live far away from a provider, how do you deal with someone who is in that position?
Well, that is a wonderful question. Thank you, Senator Cardin, and it is a challenge. Certainly, transportation continues to impact us all in rural areas. There's, the counties contribute to that. We have public transportation, but again, there's often not enough of it. Mm-hmm. We're grateful for the Medicaid coverage for transportation, and my understanding is there's some movement to also provide coverage for transportation for dental patients as well. Which is very important. But, for the chronic care management piece, patients come in, they see their provider multiple times a year, depending on what the condition is and what their health looks like. But this is where some of the efforts of the Maryland Primary Care Program come in, and what we term population health, where we wrap around the patient and we work with the patient and their family to ensure that they're taking the medication correctly, that they understand how to do that they understand their care plan. So going over a lot of those health factors and assessing health literacy, looking at their social determinants of health, all of those pieces are critical, especially in rural areas when we are looking at getting people back in for care.
As you can see by the number of senators who have participated in this hearing, there's a great deal of interest in our committee in regards to rural health care. There have been lots of initiatives, and we've tried to include that in some of the major bills around here. I think this hearing has been very helpful for us to focus on the areas where we really still need to make progress and providing the right incentives at the federal level in partnership with the other stakeholders we have in order to fill the needs that are out there. I really congratulate each of you for innovative ways to deal with rural health care in your service areas, because you've all come up with ways to help fill the void, knowing full well there are areas that you just are going to be frustrated about. Getting enough providers in your community, getting enough training facilities in your community, knowing that that's where people like to stay. But it's encouraging to see what you are able to provide for your community. So I congratulate each one of you for your commitment to the health care of your communities.
Mr. Chairman?
Senator Carpenter.
Before we adjourn, I want to touch on workforce one more time, if I may.
Certainly.
If I could. I asked my staff if this question has been asked already, was told that it has not, so I want to go ahead and ask it. Well, we have a major healthcare provider in our city. It's called Christianacare, and it's huge for a little state. And we have any number of smaller hospitals and federally qualified community health centers. I stay in close touch with almost all of them, my staff does. And one of the things I recently discussed with the people who run Christiana Healthcare, large facility, large healthcare provider, among their challenges, workforce. And it's not just the federally qualified community health centers. It's just about everybody. And we find that almost every employer that we talk to, I do a lot of customer calls with businesses, large and small, throughout my state, and we hear this all the time. And let me just, if I can, Dr. Holmes, based on your research background, could you just give me some idea of which ways in which expanding provider training at rural health facilities have demonstrated success in increasing the rural health workforce? Again, I like to say, find what works, do more of that. Just give us some examples of that.
Yeah, sure. Thank you for the question. So I think the first one I'll come up with is the Rural Residency Planning and Development Program, which was rolled out by HRSA, I think, 3 years ago, to help spur physician residency programs in rural areas and give them the technical assistance to launch them. There have been more rural residency slots created in the last 3.5 years than in the prior 6 years, I think it was. So it really shows that intentional and federal investments in expanding that can really pay a dividend. We've talked a few times about this notion that having training in rural areas is more likely to keep you practicing in there subsequently. So there's a through line between those two that really directly connects that.
Good. Thanks for that. Anyone else want to comment on this, please? Yes,
One
please,
quick
Dr.
comment is that we built this healthcare system on the largest group of high school students and college students that ever went through in America, and that workforce is not available anymore. Unless we get a disproportionate share to go into healthcare, we will never be able to staff healthcare like we have before. So it'll require a lot of different innovations for us to not only treat people more efficiently and more effectively, but find ways to keep people well, to reduce the burden on the healthcare system, and more importantly, reduce their burden of illness.
Say that again, find ways to help people. Could you say that again? To keep them well. Go ahead, say that again. I'm a big believer in that. Go ahead. Just repeat it.
What I just said?
Yeah. Just the last part of what you said.
Yeah.
Great. It was a great truth.
That if in order for us to really meet the needs of the population has to be well. And making the investments up front to keep people healthy and to decrease the burden of their disease, decrease our need for healthcare providers, decreases the costs for healthcare, but most importantly, keeps people well. People don't want to be consumers of healthcare. People want to be well.
Where does obesity fit into that, if at all?
Obesity is huge. We've just done a study of our healthcare system, largely rural. When we look at the number of the patients that are hospitalized, more than 40% of the patients that are hospitalized at any given time in the 14 hospitals across our system have a diagnosis of diabetes. That may not be why they were admitted to the hospital, but the comorbidities associated with the diabetes are likely the thing that brought them in for hospital admission.
All right. Thank you very much. Thank you all very much. Great to see you.
We know that Senator Thune was tied up in another committee. He was planning to come by, so we're going to keep the right on cue. He's been out there for 15 minutes waiting for me to.
Chairman?
Senator Thune, the floor is yours.
Thank you for making it possible for me to get here, and to Senator Daines for having a very important hearing to discuss access to health care in rural communities, which is critical certainly in my home state of South Dakota. And I want to thank our panelists for joining us today and the work that you are doing in your communities to improve access to health care. We got a lot of, strains put on rural health care providers by the pandemic, and in some very difficult circumstances, the challenges of attracting and retaining workforce is become even a more significant issue that they have to deal with. And we've had providers in South Dakota work really hard to find innovative solutions, how to reach patients, but there are still barriers. And I look forward to working with my colleagues on this committee advancing solutions that will meet some of those challenges. Let me just say, I've heard from many of the hospitals in South Dakota about the impact of the workforce shortage that it has on their ability to discharge patients from the hospital. Often, even though a patient is ready to be discharged to a long-term care facility, because the long-term care facility has a shortage of staff, they aren't able to take these patients. In South Dakota, these patients are waiting as much as 45 days in the hospital to be discharged. In one recent case, a patient waited 150 days before being placed in facility, and then it was to a facility in a different state far from his family. Further, I'm concerned this issue could be exacerbated by a potential requirement from CMS that would mandate staffing ratios in nursing homes, something we've heard a lot about. So we need to ensure that burdensome regulations do not get in the way of providing high-quality care for patients, and instead we need to work on tailored solutions for our rural communities. So, Dr. Holmes, you mentioned that in order to grow the rural health workforce, we need to support healthcare workers across their entire career. At the federal level, there are grants to support training and loan relief to recruit providers to certain areas. What other ways can we help support providers to both train and remain in rural areas?
We've talked about the bonus payment program earlier, so that would be another option to continue to make it more financially sustainable to practice in rural areas. It's not just getting them there, but keeping them there to that point.
Right.
We know that workplace violence has been on the uprise for a while in terms of, I guess, really anger at many healthcare workers, and what can be done in that space.
We've got, and I'm sure you guys have covered this already, but this mandated staffing ratio, nursing ratio issue, talked about that, exhausted that at some length. If you've already talked about that. If you haven't talked about that, I'd love to get your reaction to that.
That's the first time that's been raised, I think.
Okay.
I believe it's about the care of the patient rather than mandating a particular ratio. It depends upon the acuity of the patient, the illness of the patient, and what the patient needs at that particular time. I think it's a very coarse tool that's unlikely to be completely successful. We have nursing professionals within each one of our facilities that know what it takes to care for a patient. I do think that if you're not caring for patients well, there are certainly regulations that allow for that to be addressed. But to mandate a ratio, I think, is a blunt tool that won't, number one, will inhibit hospitals from being able to provide the care they need to provide, and will not have the intended outcome of patient safety.
And I hope they'll take that into consideration and relook at that. Unfortunately, increasing the pipeline of providers in rural areas isn't going to happen overnight, and telehealth has been as good a bridge as we have for getting there. I continue to work with my colleagues on the Connect for Health Act, which would eliminate barriers to telehealth and Medicare, including allowing rural health clinics to provide access to services through telehealth. Ms. Ani, during the pandemic, rural health clinics were able to act as distant sites for telehealth services, enabling many patients to have access to health services. Could you tell us more about your experience using this flexibility during the pandemic and how making this permanent could benefit patients?
Yes, it was very beneficial to patients. Like everyone else on the panel has said, we use a lot of audio only because our community may not have a computer or internet. So if we could integrate that some way within a payment system would be great. We have a lot of providers that will just call the patient because the patient will call day of appointment, say they can't make it because they don't have a ride to the appointment. They may be 60 miles away, and so the provider will actually just do a telephone visit with them, and a lot of the times those aren't even billed because patient or provider doesn't bill them, or their call with their results and stuff. So
yeah. Well, and the Connect for Health Act does permanently add rural health clinics as a distant site, and we have 58 rural health clinics in South Dakota. Do I have time for one more, Mr. Chairman? Sorry, I know you're... So anyway, we've got 39 critical access hospitals across the state of South Dakota, and these hospitals serve an essential, as essential healthcare provider in areas where there may not be another healthcare facility. Dr. Herman, you highlight the challenges that Essentia's critical access hospitals face with arbitrary regulatory requirements like the 96-hour rule. As you know, this rule was waived during the pandemic health emergency. Could you describe how the waiver of this rule during that during the health emergency, help critical access hospitals better serve patients, and what challenges are those hospitals now going to face if the rule's back in place?
We firmly believe that the best care a patient can get is the care that they can get closest to home. You have the support of your family and you have the support of your community, and we know that those are incredibly important in promoting the wellness and the healing of the patient. What we saw during the pandemic is that waiver of the 96-hour rule did several different things. First of all, it allowed those critical access hospitals to retain their staff. When you have widely fluctuating census, it's hard to keep the staff because people work Monday and Tuesday and then they don't work for the rest of the week. Number two, it allowed them to really build their capabilities to take care of sicker patients. They became more confident in their ability to do that and allowed them to keep those patients closer to home. Our concern is, and the other part of it was, is that we did not have the capability in the larger hospitals to take care of those patients. A lot right now towards the post-acute care, there's about 2,000 patients every day in Minnesota hospitals that are waiting to get to a skilled nursing facility or post-acute care. Where do those patients go? If we can stabilize the staff and build the capabilities of those critical access hospitals, I believe it'll go a long way to their success in the future.
Okay. Well, we look forward to working with you on that. And, Mr. Chairman, I thank you again for giving me the time.
Sure.
Thank you.
Thank you, Senator.
Thank you all very much.
We want to thank the entire panel. This has been an extremely helpful presentations. It'll be used by our committee dealing with these issues. The record will remain open until next Wednesday for members to ask questions for the record. And again, with our thanks to our witnesses, this hearing will now be adjourned. Thanks.